Hi, this is some supplemental information for anyone who's having trouble with figuring out dropped beats, sinus, pause or arrest, ventricular or junctional escape rhythms, or premature contractions. I'll also cover briefly blocks and conduction delays. The first topic is dropped beats. Here we are talking about the loss of an entire PQRST complex. The SA node is blocked somehow, and we have a full dropped beat. What you'll notice is that before the dropped beat, the rhythm is regular, the beat drops out, and then the beat goes on. So after the dropped beat, the cycle continues on time, meaning that you could insert the dropped beat into the space and everything would march out with a correct R to R interval. This is in contrast to a AV block, a second degree block, where just the QRS complex is dropping out. You will see in an AV nodal block, you may see a P wave without a QRST complex. Here, we're missing the entire complex. And that's because the SA node has been blocked. Sinus pause or sinus arrest. So this is absence of electrical activity initiated by the SA node as well. The amount of time varies. A pause of 6 seconds is likely to result in severe symptoms, hypotension, and may require medical intervention. In a sinus pause or sinus arrest, the rhythm typically has a constant R to R interval prior to the pause and after, but the rhythm will not pick up where it left off, and the period of pause is not regular or predictable, i.e., it's not a multiple of the normal P to P interval, meaning that you can't just insert the appropriate number of PQRST complexes. The pause will not allow for that PQRST complex to be put in a regular fashion. Ventricular or junctional escape rhythms. So for these, the rate is slow because the heart is being paced by either the junction, which averages 40 to 60 beats per minute, or the ventricle, which is even slower at 20 to 40 beats per minute. This means that the SA node is not firing at all, and the heart is being paced by a much slower pacemaker. This can result from a sinus arrest, or high-grade third-degree AV nodal block, or even beta blocker or digoxin overdose. Remember, if you go back to think about the pacemaker cells of the heart, the SA node paces between 60 and 100. The AV node is pacing between 40 and 60, and that's the junction. And then the ventricle is pacing even slower, between 20 and 40 beats per minute. If we look at this 12-lead EKG, we can't discern any P waves. There's a little blip there, but even if it is, it's very prolonged. But I can't see any other P waves. And the rate, if we count it out, is also quite slow. 300, 150, 100, 75, 60, 50, very slow. So this is a very slow junctional rhythm. And what it's meaning is the SA node is not firing, and then the junction or the ventricle kicks in. If the QRS complex is narrow, it's probably coming from the junction as well as the rate. If the QRS complex is wider, greater than 3 small boxes, this is probably coming from the ventricle. And if I look closely here, Sorry about that. If I look closely here, this does appear to be more than 3 small boxes. And this is probably coming from the ventricle and is in fact a ventricular escape rhythm. Premature beats or contractions. So a premature heartbeat occurs when the heart's regular rhythm is interrupted by an early or even an extra heartbeat. You can have beats arising from the atria, the junction, or the ventricle. A premature beat arising from the atria is called a premature atrial contraction, or a PAC. A beat arising from the junction that occurs prematurely is called a premature junctional contraction. And then a beat arising from the ventricle is called a premature ventricular contraction, or a PVC. PACs or PVCs can sometimes be felt as a skipped beat. The resulting heart contraction doesn't produce enough blood flow to the body, and a small pause is felt, but often the person feels the following heartbeat is more forceful than usual. And so this may be a symptom of a patient complaining of palpitations, or a finding in a patient complaining of palpitations. If the PAC or PVC is less premature and the heart did have a little time to fill with blood, it may feel like an extra beat rather than a skipped beat. And at times, these beats may not be fully conducted. In most cases, neither a PAC, a PVC, or a PJC are considered serious in isolation in most healthy people, and you can find them commonly in many ages. Caffeine, alcohol, stress, and fatigue may cause PACs or PVCs to occur more frequently. If the symptoms caused by premature beats are bothersome, they can be treated with medications or catheter ablation. PVCs that occur in frequent couplets or with increasing frequency may be a sign of cardiac irritability as well, but generally considered benign. These are examples side by side of premature atrial contractions, premature junctional contractions, and premature ventricular contractions, just so you can see the difference in the morphology. In a premature atrial contraction, there will be a P wave. It will look a little wonky, so it will look a little bit narrow when you compare it to a regular P wave in the rhythm. And as you can see here, this was 300, 150, 100. So we have a sinus rhythm here. So this sinus, this R to R ratio is consistent. And unfortunately, the beat came a little bit too soon. With this premature atrial contraction, the heart was able to reset on time and continue on. So this complex just fired a little too soon. Down below here again, the R to R interval is difficult to discern because this patient has PACs that are coming kind of in a pattern. Sometimes if they come in a 2 or 3 pattern, we may call it bigeminy or trigeminy. Again, here's the P wave that looks a little wonky, a little skinny, and a little taller than the expected P wave. And again, here's another premature atrial complex with the same P wave morphology. In the premature junctional contraction, the P waves are absent or inverted. So this R to R interval is constant, however, and there's a P wave for every QRST. However, there's a QRS complex, a slight, what seems to be a pause, and then it goes back to a PQRS complex. And if we look at this closely, there's no P wave here. So this is a premature junctional complex. The other thing to note about these junctional complexes is that they're narrow. Here's one more example down below. This is a P wave QRS, and where we would expect to see a P wave, we don't really see one. We see a QRS complex, and then PQRS, and so forth. So this is another example of a premature junctional contraction. So a narrow QRS that fired a little bit sooner than we expected, and there's no P wave. Again, contrast the premature junctional complex to a premature atrial complex. So there's a distinct a distinct P wave here in the PAC, but there's no P wave in the PJC. Lastly, we have premature ventricular complexes, and these demonstrate a wide QRS complex that is misplaced and misfired too early in the sequence. For example, on the top here, we have a P wave QRS complex, narrow, T wave. Repeats again, P wave QRS complex, T wave, and then we have this wide squiggle. We see that this is definitely wider than 3 small boxes. It definitely occurred prior to where it's supposed to, but then the beat goes on. It picks up again, a P wave, narrow QRS, and so forth. So we know that this is a premature ventricular contraction. And again, there's really no discernible P wave, but these are very striking because the QRS complex is so wide. Again, down below, we have an R to R interval here, so 300, 150, 100, 75, so a little less than 75. P wave, narrow QRS. Again, P wave, narrow QRS, P wave, narrow QRS, and then we have a very wide QRS complex, which is a PVC, and then back to our regularly scheduled normal sinus rhythm. So briefly, I'm now going to cover some other blocks, right bundle branch blocks, left bundle branch blocks, and fascicular blocks. We reviewed AV blocks in the first lecture, first, second, and third degree AV blocks. I want to remind you briefly of where the fascicles are in the conduction fibers of the heart. So we have the SA node, the conduction will travel to the AV node, the bundle of His, and then the left bundle and the right bundle. The fascicles are actually distal to the left bundle branch. And so there's the posterior fascicle and the anterior fascicle, and then out to the Purkinje fibers. As a reminder, again, this is the flow. I liked the picture before just because it gave you a little bit of anatomical perspective. If there is a block of the right bundle, the depolarization will continue to the left bundle, septum, fascicles, the left ventricle, and then the conduction will ultimately then pass over to the right ventricle, bypassing the block. However, it's a much slower conduction because it's going farther around. The same is true here. If there's a left bundle branch block, the depolarization wave will continue to the right bundle, to the right ventricle, and then the wave will make its way to the left side. But again, that's a very long conduction delay. When we have blocks in the left and right bundle, we will often see very unusually shaped QRS complexes. And they're usually very wide and have some characteristic appearances. The major changes in blocks are in the shape and duration of the QRS complex, since it's ventricular depolarization that has been altered. When we look specifically in the precordial lead V1, we notice that the right bundle branch block has a characteristic R wave, S wave, R prime, S wave appearance to it. This is often referred to as, quote, bunny ears. In the left bundle branch block, this will be a wide appearance, but in lead V1, it tends to be a downward deflection from your isoelectric point. In lead V6, this is the normal QRS complex, the right with a right bundle branch block, we don't see the RR prime as frequently. We do see in the left bundle branch blocks in lead V6, we will often see an unusually shaped R wave with a notched appearance at the top. And again, these are wider complexes, much wider than 3 small boxes. Same as here in lead V1. This QRS complex is wider than 3 small boxes. Again, this is just another image, the R prime for right bundle branch block, and then for left bundle, a downward deflection in lead V1. In V6, it tends to appear to have a notched appearance of the R wave, and sometimes you have to look very closely there, but they will always be greater than 3 small boxes when you're considering a bundle branch block. So when you are evaluating your rhythm or your 12-lead EKG, part of the algorithm is after you determine the rate, after you've looked at the P waves, you look at the QRS complexes. If you've identified that your QRS complexes are in fact wider than those 3 small boxes, you can go to lead V1 and V6 to try to look at the morphology of the QRS complexes. If the terminal force of the QRS is above the baseline, meaning predominantly upward deflection, you have a right bundle branch block. If the terminal force of the QRS is below the baseline, so you have a big S wave, you have a left bundle branch block. There is, of course, a handy mnemonic associated with this, and it's William Marrow. So for a left bundle branch block, we see a widened QRS in lead V1, and then in V6, or the high lateral leads, we see a notched R wave. And we can imagine that this looks like an M. And so wide V1, M-shaped or notched R wave in lead V6 is consistent with a left bundle branch block. For a right Marrow, we see in lead V1 or V2 in the precordial leads, we see this R prime or bunny ears, which, if you imagine, looks like an M. And then in lead 1 or the other leads, we will see a widened QRS complex. The L, of course, in William means left, and the R in Marrow means right. If, by chance, that is tough to remember, I have another quick kind of cheat way that I'll show you in a minute. In a right bundle branch block, typically there's a normal P wave. The QRS complex is wide, so greater than 3 small little boxes. Remember, each box is 0.04 milliseconds, so 3 tiny boxes is 0.12. So bigger than 3 tiny boxes or greater than 0.12 is considered a wide QRS. A QRS in V1 appears to be M-shaped or bunny ears, also called R prime, and that's what the R1 means. Prominent or wide S wave in leads 1 and AVL. V6 will often appear normal. This having a right bundle branch can limit the ability to determine right ventricular hypertrophy, as well as STEMI in some cases. Left bundle branch blocks, so typically normal rate and rhythm, typically normal PR interval, typically a P wave of normal morphology. What you see over here is actually someone in AFib, so there's no P waves. But typically, if the underlying rhythm has a P wave, so will these. QRS complexes, again, are wide at greater than 0.12 milliseconds, and they are bizarrely shaped. And so in V1, we see the bunny ears phenomenon, but these are going to be deflected downward. The R wave looks wide in lead 1. So here's the R wave. So there's no P wave. This is the RSR prime, and it looks wide and weird. And the beginning of this can be mistaken for a P wave. However, there are no P waves if you actually look at all of the leads. The T wave is abnormal as well in morphology because repolarization cannot occur normally if depolarization is abnormal. So remember, the QRS-T complex represents ventricular depolarization and repolarization. And so the T waves will often look abnormal in these blocks as well. Left bundle branch blocks limit your ability to determine left ventricular hypertrophy as well as an ST segment elevation myocardial infarction or a heart attack. And again, this tracing, the person has AFib, so you don't see the P waves. So the P waves can be there. It's just what the underlying rhythm is that the left bundle branch block will be in addition to the underlying rhythm. So here's the kind of cheater way of determining whether you think it is a right bundle or a left bundle branch block. If you take your EKG and you are applying your algorithm, first you would figure out the rate. Then you would look for P waves. And then you're going to look for your QRS complexes and see if they're wide. And in this tracing, as well as this tracing, these QRS complexes appear to be wide and greater than 3 small boxes. So the next thing to do is flip the EKG 90 degrees clockwise. Then if you look at the precordial leads, which way is the QRS complex pointing in leads V1 through V3? And so you say the predominant direction of the QRS, is it above or below the baseline? So QRS below the baseline, aka pointing to the left, direction by the arrow. So you can see on this left side, the predominant direction is downward deflection from the baseline, and it's pointing to the left. This, in fact, represents a left bundle branch block. And you can double check yourself by looking at the notched R waves in V6 and a wide QRS that looks kind of like a W in leads V1 and V2. Again, over here is the QRS above the baseline, aka pointing to the right. So it does appear the predominant direction in the leads V1, V2, and V3 is in fact above the baseline and or pointing to the right. And so you have a right bundle branch block. And if I check myself here, I can say that in lead V1 and V2, I have an RSR prime, and over in V6, this is okay. If I look in lead 1, this also appears wide here. This appears to be a right bundle branch block. Fascicular blocks. So these occur more distal to the left bundle. Left anterior fascicular block, slightly prolonged QRS, but not very wide. So not greater than 3 boxes. There tends to be left axis deviation. So here we have lead 1 is positively deflected upward. Lead AVF is downward. So we do in fact have left axis deviation because we also have a downward deflection in lead 2. We note QR complexes in leads 1 and AVL, which means there's a small Q, downward deflection, and a large R, but not really an S. Again, Q, R, not really an S. And then in leads 2, 3, and AVF, the inferior leads, we see an RS complex. So we see an R wave with a deep S, R wave with a deep S. And again, here, both in leads 1 and AVL, the depolarization is going towards those leads, And in 2-3 AVF in the inferior leads, depolarization is going away from these leads. A left posterior fascicular block, you may again see a slightly prolonged QRS, but definitely not a widened QRS greater than 3 small boxes. You'll often see right axis deviation. And so if we apply this appears to be downwardly deflected in lead 1. It appears to be upwardly deflected in AVF. So we have right axis. We see a QR complex in the inferior lead. So there's a very small downward deflection here with an R wave in 3, Q and an R in AVF. Very small downward deflection, so a little Q and a R wave. In leads 1 and AVL, we see an RS. So we see an R wave with a deep S, and again an R wave with a deep S. There's absence of right ventricular hypertrophy or prior myocardial infarction when you see this. You may have somebody who's had a prior heart attack or has RVH, and these rules kind of don't apply to that. So hopefully this was help in explaining some of the more odd waves that we see and the pauses and the blocks. Let me know if you have any questions. This was to supplement your online course as well as your readings and books, the Huff book and other resources.